And we'll move to our first presentation. I'd like to welcome Ms. Angela Montesanti Porter and Dr. Heather Scobie from CDC, US CDC, and they'll be talking to us about data triangulation for improved decision-making in immunization programs.
Hello, I'm Heather Scobie. So data triangulation is the synthesis of existing data from two or more sources to address relevant questions for program planning and decision making. It identifies and aims to address the limitations of any one data source or data collection methodology, and it encourages deeper insight through making sense of different information in broader context. Triangulation is a bit like the parable of the blind man and the elephant. One man feels the trunk of the elephant and thinks it's a snake. Another feels the ear and thinks it's a rug. And altogether, their collective experience gives them a more complete picture of the issue at hand. CDC undertook a landscape analysis to try to identify the different ways that triangulation was used by the immunization program, and we came up with 5 different uses. One was checking consistency of data across data sources. This may be the way you're most familiar with using triangulation. A second was as a diagnostic to target program interventions like a risk assessment. Another was estimation of coverage, target populations, or disease burden. This may, you may be familiar with the example of the WUNIC estimates of coverage. But the point is that it's not just data validation. So CDC, in collaboration with WHO and UNICEF, developed some draft guidance on triangulation for improved decision-making and immunization programs. This guidance is available at the TechNet website that you see there. And the schematic shows an outline of the different documents that are available. So there's a cover and orientation to the guide, and then there are documents for the national and subnational level. And at each level, there's a general overview about triangulation and the methods to do it. And then there are topic-specific annexes that give examples on how to deal with immunity gaps, program performance, and program targets or denominator. Minimal criteria for triangulation are access to 2 or more data sources and having data management and analysis capacity, and the willingness to take action on results. The format of the exercise will vary based on the level, whether it's at the subnational or national level, and the frequency, whether it's routine or ad hoc. We can say that there are different principles of triangulation that you should try to implement. The first is that it should be driven by important program objectives or questions. You should use existing data. No new data need to be collected. You should include diverse data sources, for example, coverage, vaccine stock, and surveillance. Try to engage a multidisciplinary team, if possible, and perform basic analysis that includes integration of local knowledge into the interpretation. Finally, the results should be communicated for use in improved decision-making. There are 2 ways that we can think about triangulating data. The first way is the way that people most often think about, where you take a bunch of different data and you put it into one analysis or graph from the start. The second way is to do separate analyses and combine through interpretation at the end, sort of like you're putting stitching together the different information into a story. Either way, critical thinking is required to turn data into information for action. We've developed this 4-step triangulation process. It's pretty basic, and you can use this process at the subnational level or for some of the routine monitoring analyses you do. It starts with asking the key question, identifying existing data sources, summarizing the data in local context, and developing an action plan. We also have a more detailed 10-step process. It fleshes out the previous process, and it's appropriate for more in-depth analyses. We won't spend much time on this. So next, I'm going to turn it over to Angela Montesanti.
Thanks, Heather. So we're going to spend the rest of the time going over in a bit more detail the 4 steps of the 4-step triangulation process and some examples. So step 1, asking the key question. You want to start by identifying key program problems and related questions. How do you hope to use this data for action at the end? The question must be answerable and actionable. An action may inform local program planning or perhaps where a policy change is needed from a higher level. You want to engage a variety of relevant staff from the beginning. This helps in getting access to data sources, reviewing example analyses and summaries, brainstorming root causes or contextual information that's needed, and facilitating group discussion for the action plan. Step 2, identify existing data sources. You want to identify all relevant data sources, including those not in routine use. It helps to talk with staff and partners both within and outside your program. Access and effort is required to compile the data into a usable format. One invaluable output of this step is creating a list of all data sources and putting them into a well-organized archive or inventory of sorts, and this aids more regular use of these data sources in the future. You also want to consider strengths and limitations of each source. Step 3, summarizing the data in local context. You want to assess the data quality, for example, looking at completeness and internal consistency within each of your data sources. You also want to evaluate trends across data sources, ideally looking at the same place and time period. You want to incorporate contextual information and local knowledge, brainstorm multiple hypotheses to explain any of your findings, and be honest about your data limitations, for example, missing data and errors. As part of the guidance, we tried to provide a bit of an analytic framework for interpreting comparisons of different data, summarized here in the table. You see in the first row as an example, comparing administrative coverage and survey coverage. You would expect these data sources and data points to be essentially the same. In the second row, you see comparing vaccination coverage in cases of disease from surveillance data. You'd expect these trends to go in the opposite direction. As coverage goes up, number of cases of disease goes down. And lastly, we'll focus on the doses administered and vials used and shipped from stock data. You'd expect these trends to go in the same direction, but different by a factor. Some reasons for this could be vaccine presentation, wasted sacrificed doses, buffer stock practices, or informal exchange networks. And this is where contextual information and local knowledge really comes into play here. Step 4, develop an action plan. You want simple key messages tailored to your target audience. You want to tell a story with your data, noting that visual information is processed faster than words, and you want a logical flow to your summaries, supported with explanatory details, and include case studies if relevant. You want to recommend actions based on your triangulation results, and some example real-life action items that have come out of triangulation exercises are here in the box. For example, supportive supervision to improve data quality, revise microplan guidance to use local growth rates, and catch-up vaccination in areas with coverage gaps. So some example key questions to get someone started in a triangulation process are listed here. At the national level, a key question could be which districts with low performance and/or inconsistencies in data quality require follow-up. At the subnational level, which health units under my supervision should be prioritized for visits or follow-up. Next, we'll show you some examples of how to investigate these types of questions using stock data. The first example is a national level analysis looking at data from 2018 of the ratio of Penta 3 to PCV3 and OPV3 doses given. You see here the number of doses of each of these vaccines in the bar graphs, Penta 3 in blue, PCV3 in green, and OPV3 in pink. You also see a reference line that's in blue, which is a 1-to-1 ratio of these 3 vaccines, because in this country, it would be expected that all 3 of these vaccines are given during the same visit. Then you see the ratio of Penta3 to PCV3 in black line, the ratio of Penta3 to OPV3 in the pink dotted line. And you see here, those ratio lines go below the reference point, the blue reference point line, a number of times, highlighted by the red arrows, indicating that less Penta was given than PCV and OPV on a number of occasions. After further investigation, the country came to the conclusion that this was resulting in, or this resulted from a number of data quality issues at the subnational level, as well as Penta stockouts occurring. The next example we'll look at is looking at Penta doses given versus vials used in wastage from stock data. This country uses a 1-dose pentavalent vial for Penta vaccine, so you'd expect the wastage rate to be fairly low. In the table here on the left, you see that Penta wastage nationally is very low, being 0.14% in 2018 and 0.06% in 2019. But the table on the right shows the disaggregation of this data by subdistrict, noting a very wide range of wastage rates. There are 612 subdistricts total, with 94 subdistricts reporting a negative wastage rate in 2018 and 98 subdistricts reporting a negative wastage rate in 2019. On the opposite end of that spectrum, we saw 12 subdistricts reporting a very high wastage rate of over 10% in 2018 and 6 subdistricts in 2019. So upon further investigation of some of these really outlying subdistricts, we show here an example of one of the subdistricts that was reporting a negative wastage rate. And some examples of data quality issues that they found that were actually immediately rectified include 0 monthly stock report on the left and discrepancies in admin versus stock data on the right. And the last example we'll show here is another real-life example from a surveillance and immunization medical officer in Municipality X. He was looking at Penta doses available and used from stock data versus doses administered from administrative immunization data from 2018 to October of 2019. You see here in the blue line, this was the opening balance of Penta for each month. Then you see in the green line, total pentavalent given in green, pentavalent vials used in purple, and then there's a reference point of what the pentavalent need was with buffer for each month. Overall, you see that they were supplied repeatedly below what was required in 2018. But from the green and purple lines, you see that there's good agreement between doses given and doses used. These red circles show that in months where there was particularly low opening balance, doses given and vials used also decreased. So this immunization medical officer presented this data to the district API office and was able to improve the supply chain. So some opportunities for integrating triangulation with existing activities. One could be through routine analysis with things like API data review meetings, annual desk reviews, ad hoc evaluations of intervention impact, outbreak investigations, including triangulation as part of data quality reviews or API or surveillance reviews, trainings, and dashboard design. So we'll end with some suggestions for how you can start now. Well, first, we recommend you review the triangulation guidance. Try using all the data you have available, including vaccine stock and surveillance. Collaborate across programs and organizations to discover additional data sources. Ask more questions to drive analyses and discover root causes of problems. Brush up on data analysis and visualization skills by reading tutorials and videos online. Identify multiple alternative explanations for results. Brainstorm different possible data-guided actions, the relative impact and related assumptions, and seek feedback from colleagues who are good at analysis or presentations. So we'll end there, except to say that there are a number of resources on triangulation available. And this first reference here, the TechNet 21 topics page on triangulation is available and includes not only the draft guidance that we've been discussing, but we've also curated a number of resources for you on this page. So we highly recommend you visit that. And also just to acknowledge that this data triangulation guidance has required effort from our immunization colleagues all over global, regional, and country level. And we just want to take a moment to thank everyone for helping in this process. And with that, we'll end our presentation and turn it over to Adriana to introduce the next presentation. Thank you.
Great. Thank you so much for that presentation, Angela and Heather. I think the guidance that's now available on the TechNet website for triangulation is sure to be really useful for our audience who may want to triangulate their own existing data. And, so now we'll move to a presentation that's a practical example of what Angela and Heather have just been talking about. And this example is from Ethiopia on triangulating EPI data and supply chain data for enhanced data use and decision making, presented by Amare Bayeh from JSI. Amare, you can take it away.
Hello, Adriana. Can you hear me now?
Yes, we can hear you.
Okay, thank you very much for this chance. So as you said, yes, let me share you some of the practical experiences JSI in Ethiopia supporting on triangulating data using different data sources. In Ethiopia, there are standardized data sources for immunization program, like other health programs. So some of them is DHIS2 for administrative immunization program, and Brana for LMIS. So the word Brana may be unique for Ethiopia, which stands M is for mobile. Brana is a traditional name that Ethiopia had been using anciently. A goat skin to write as a paper using a locally prepared ink. So we call it Brana. So this is for vaccine or immunization supply chain data dashboard. So these are the main data sources for triangulation. And nationally and subnationally, there are a number of challenges on quality of data, like timeliness, completeness. At the same time, these data sources are separated, and there is a limited data sharing habit between these two departments and very weak coordination. And subnational or regional immunization officers do not regularly review data for program improvement, and actually are not involved in leveraging or reinforcing supply chain data at their level. Yeah, so due to this, JSI was started thinking strategically how to support these two important data sources bring together, and arranged a consultative workshop last year with key subnational government officers like the managers, the DHIS2, supply chain, and JSI, subnational, national, and headquarters staffs for 2 days. And this group discussed on the key issues and barriers to data use and triangulation for program improvement. And finally, they come up with some priority action, which is develop a user-friendly tool that could bring these two important data sets together for analysis, interpretation, understanding, and use of the information for action. So during the designing, we have taken 3 important activities. The first is developing the tool, the dashboard, how to bring these two data sources together, and developing the user guide, how to use the tool, and the guidance to conduct review meetings among team during meetings. And at the same time, we started rolling out of this data at the regional health bureau, or that subnational level in this case. And I assigned key persons from each department to enhance accountability and commitment as an EPI officer, as a team lead. and conduct a meeting and identify and develop action planning during the meetings. So during the rolling out, GSI closely monitors the implementation and analyze on use of the data. For example, GSI staff joins the review meetings and conduct user documentation and discussing with the key informants. So that especially the user documentation helps to get more feedback on the tool, the feasibility, usability, and how this helps to review and understand the existing data between these two important data sources. At the same time, there will be a continuous documentation of the process, just to clearly understand how this tool really helps for program decision. This starts from the analysis, identification of action points for decisions, and the type of action taken for improvement. And this will be a cyclical or a continuum activity. So we will also discuss and document this one. So during this data triangulation tool development, we have taken a number of backend for the steps, starting from the identification of and defining key indicators up to testing, retesting, and refining of the tool, and then come up with a draft tool. And we identified 6 key indicators from these two data sources. And we also determine the operational definitions for this, for each indicator, and create target ranges for each indicator, what it does mean for that specific indicator. And then create triangulation composite score. First, there is a color code for each score, each indicator based on the target range, and then add up all 6 indicators to get a composite score. So this each indicator and composite score will be measured and color coded: green, yellow, and red. And this type of coloring is important for the reviewing team, just to see the magnitude of the problem. And this is an example for one example indicator, that is ratio of total Penta administered to Penta issued. So the tool generates automatically the range, and at the same time the color. That's green with ACC with this range, and yellow from 0.8 to 0.95%, 0.95%, and red. So the tool again gives the results or the action taken based on the color. So this is an example. This is the first page of the data triangulation tool. As you see, it contains the purpose, the instruction, so as a first page, and also tool navigation. There is all icons for users, so that one can click, open, and use any amongst the listed tools. And again, this is an example for a data entry tab, DHIs to data entry. So the working team copy from the monthly immunization data from the standard DHIS report and paste here, and select the month, year, and then submit. And the same is true for Immunization or the vaccine supply chain data. So they copy and paste from the mother document, and then automatically submit, and automatically they go to the dashboard. So the first dashboard is the regional level or subnational level dashboard. As you see from the left column, the districts. A region contains a number of districts, more than 200, or at minimum 20 or 30 districts. So the tool gives the previous 6 months of finding based on the color. So this is the composite score for the district. At the same time, as you see from the right side, as a summary, the region has a number of zones, and a zone contains a number of districts. So automatically the tool gives the score, how many districts scored green, yellow, red, and at the same time it gives the missing data from each district. And then automatically go to the district dashboard. And interestingly, the district dashboard shows the result by indicator. So this is each indicator will be evaluated separately for specific every month actually, and gives the previous overrolling of the 6 months. And the tool generates the action to take for each color, for each indicator. So which is important, and it's very easy for the review team just to see the key findings. And as you see from the lower part, the district also, this tool monitors the red categorization. And as you know, the red categorization is measured using Penta 1 for coverage for access, and Penta 1, Penta 3 dropout rate for utilization, and gives automatically the category 1 up to 4 for each month, and then gives the action to take for each category. So automatically the team discusses on the findings. So currently the implementation is ongoing, and like the tool is rolled out in 2 subnational level, and conducting a tool usability assessment just to have more feedback and revise or adapt before rolling, and also conduct informal key informant interviews with users to understand how the tool facilitated data review that not happened before, or how this tool helps us to review data differently, and also to understand how they have used the data from this data triangulation, and also how this tool will be institutionalized and into the existing monitoring or data quality improvement and decision-making system in the health system in general. So in general, what I would like to say is it is very important to facilitate integrated data analysis, which is not happening currently in Ethiopia. And it helps to enhance the capacity for data quality improvement, as well as data is for decision making. So I think this is a very important thing, and such type of analysis can be replicated to other countries interested to triangulate immunization program data with immunization supply chain data. So this is all. Thank you very much.
Great. Thank you very much, Amare, for sharing that practical example case from Ethiopia of instituting regular data triangulation and data review processes. I think just from the first 2 presentations, we can see how important it is to get the right people in the room for that data use and decision making. And I think that's actually a nice segue to our final presentation. And this will be with Harrison Mariki and Daniel Kinyanjui, and they will talk about impact teams for supply chain management.
Thank you, Adriana, and thank you everyone who started this great presentation. So this presentation will be done by myself, Harrison Mariki, and my colleague, Daniel, who will join me later in the presentation. And we'll be talking about impact teams. These are data use teams, and in other areas they're called data use teams, in other areas they're called quality improvement teams. But basically how they can help to improve use of immunization data and also the quality of this data. So just to, so first to start with, to introduce what inSupply is. So inSupply Health, we are a local registered company in East Africa. We are an affiliate of JSI. What we specialize in is developing maturity strategies and we support the Ministry of Health and the programs for that. We help in building capacity in supply chain management and designing and implementing data-driven optimized supply chain systems. So we've done some work in strengthening forecasting health commodities, including immunization. And we have done this in both Kenya and Tanzania. So to talk a bit about impact teams. So impact teams, these are a system of interconnected people. They are multidisciplinary. So they are usually at national level, subnational level, and even at facility levels. And in other areas, so in Kenya, our colleagues in Kenya tend to use county and sub-county level, but basically it's just national, subnational level. And what they do is they are trained to use structured and problem-solving methods to help to solve their issues. So the innovate, do, review, which is part of quality improvement teams, is essentially what drives the impact teams. And this initiative, when we started in 2018, and it was we did a desk review and looked at where it has been done and implemented by JSA in different areas, and we see that it was implemented in multiple countries, and also it has worked for different programs. And so we went ahead and implemented this in Kenya and in Tanzania. And in Kenya, in 2018, between the period 2016 and 2018, we were able to implement this in 17 counties. What we learned, it helped, especially for at that time, we were rolling out the RTMD devices. And so the study that was done at that time, it helped to improve the uptime recorded in those devices. But also we noticed there are still the challenges around industrialization of and sustaining the approach moving forward. In Kenya, in Tanzania, we are also currently rolling out this system, and it's in 13 regions out of 26 regions. So, and the good thing about this, there is good ownership by the government, and different partners are implementing this. So the Global Health Supply Chain, inSupply Health, THPS, and several other implementing partners are doing this across the country. But also, though we see good ownership and we see some performance, we also notice some challenges around monitoring and supporting the approach as scaling to more and more regions. So we found ourselves with a very important challenge on how we would institutionalize or sustain this approach in Tanzania, in Kenya, and in other areas if it's taken up by other areas. So we thought of what would be the best ways to do this approach so that we can continue to see the results, but still the approach continues to be sustainable and also scalable. So we did a lot of evaluation. We used human-centered design. Also, we tend to use adaptive learning in most of our projects. So those are some of our strengths. So what we do, we did the evaluation of the approach and how we did it before. We developed implementation packages and adapted them to the context of Kenya and Tanzania, and also that can be applied in other low-income countries. Also, we collaborated with various partners to develop these packages. So this is part of the HD and adaptive learning approach as it was happening. So we identified the right composition of the impact team members, or like, so what is the right skill mix that is needed within a data use team for it to be effective, for them to be able to, for instance, triangulate data as we have been talking about in the previous sessions. And also what will motivate for the teams to be meeting regularly and using data consistently. How would it be overcome barriers to action and escalating the issues to people beyond those within the impact teams? And also, how do you keep recognizing good performance and encouraging people to do better? So some of the insights that came out of some of the HCD work that we have been doing, we noticed that decision support tools are key. So the teams needs to have dashboards or tools that help them to make those decisions easily. So if you are able to automate them, that's even better. So having an ELMIS or a Embrana, for instance, that provides this good visualization is a key. Also having the right skills and capacity within the teams, and for that you'll see in the next slides we'll talk a bit more about the different skill set that are needed within the team, and also to have leadership within the team. And this is not just hierarchical leadership or the titles, but having leadership skills within the team. So leadership beyond the normal. So, and we noticed as we are looking at the different teams, the maturity of the teams in terms of using their data was very much dependent on the levels within these categories, as you've seen from these insights. So one key area also that we noticed, and I said we'll talk about this a bit, is the composition of the team and also the skills needed within the team to be able to review the data. Previously, in our previous implementation, we had used a different framework in terms of operationalizing the impact team. So we always focused on looking at the people, processes, and data framework. And we use that usually to categorize the teams in terms of these are best performing, these are moderate performance, these are low performing, and tailored our support to them based on that. But when we started shifting towards the new way of using personas and looking at the skills of those particular people, we noticed, okay, actually this is much better because you can actually know who to help and how to help. So I'm going to allow my colleague, Daniel, to speak a bit about the different role profiles that we see are important within the team, and the skills, and also what we think are innovations that can help to build those skills. Welcome, Daniel.
Thank you, Harrison. Based on the HCD that we conducted, we identified key data use roles based on knowledge, skills, competencies, and other needs which is required for impact team to create a meaningful change. These personas are divided into core and enabling roles. And from the HCD, we realized that the core roles are the anchors. These are people who should be present in each and every meeting. Then we have the enabling roles, who are not required to attend every meeting, but their support is key. They play a great role behind the curtains. So for the core roles, we identified organizing auto, who calls for meeting and also ensure that everything is in place in terms of agenda. Then we have Peter problem solver, who is also key in terms of solving the key supply chain challenges. Then we have the data with Diana, who provides the data that is key in supply chain decision. And finally, on core roles, we have supply chain Sam, who has deep understanding of supply chain processes and challenges. So after rolling out this assessment, Harrison, if you can.
Oh, sorry.
Yes, these are key results from Kenya, and we identified that in Kenya, one lesson that we learned from these results is the fact that different sub-counties have different data use capacity, building needs, and it cuts across the different profiles. And this one is serves as a cue for their capacity building needs. We also had an assessment, and in terms of the supporting profile, Harrison? We have one other lesson that we learned from this is that these role profiles are mostly in another different level, in an advanced level. And so for most sub-counties, the scores were a bit low because they are enabling role profiles and they are not required for each and every meeting. We also rolled out the assessment in Tanzania. And in Tanzania, we noticed that there were some role profiles that required capacity building. And some of these role profiles that stood out include the influencing Irene, Peter problem solver, and also the resource reader. So having the right team on the ground and having the right people at the table helps us to discuss the different data. So we're using a combination of indicators. Impact teams are able to monitor immunization supply chain and identify areas of focus and how to improve performance. So tracking reporting rates allows the impact team to know or measure the data availability and also availability of that data to inform supply chain decision. Then we also track stock status to determine if the supply chain, the immunization supply chain is stocked according to plan. One other indicator that we track is the stockout rate, which measures the service delivery points that are experiencing stockout. So by looking at these indicators, you are able to determine the productivity of your supply chain. And of course, this is measured by the immunization supply chain performance, and this you'll get from coverage. We also implemented the same in Tanzania, and in Tanzania, we started with completeness and timeliness of data, but now the program has introduced additional indicators for immunization performance, and we are looking at stock status and also trying to monitor the cold chain equipment. I'll hand it over back to Harrison for continued adaptation.
Thank you so much, Daniel, for taking us through that. So what we learned with the assessments, for instance, that we did in Kenya and Tanzania, so we are evolving the decision support tools. So we are looking at the tools to do more triangulation. And apart from just having to look at, for instance, for the regional or county level, because those are areas where also we are looking for the resource reader, the leaders to be in that areas. So the decision support tools will also include process indicators that look at the lower levels. For instance, are they meeting and reviewing the data? So we are adding more and more indicators that can support those roles as well. Something else that we are doing is we are developing self-directed online learning packages to support the impact teams to build their skills. So this week, for instance, we'll be rolling out our first package for supply chain SAM, which covers all the competence needed for supply chain SAM. The next one will be for data with Diane, and we'll keep rolling them out. And our approach is to roll them out and get feedback from the users and iterate as we move forward. We talked about this also in the previous slides, that in Tanzania, for instance, right now we have started to develop indicators for CC monitoring, and this is work that is happening in both Kenya and Tanzania. So how can we ensure that we build centers of excellence in terms of supply chain management, where each child is vaccinated with not just vaccines, but potent vaccines. So we are adding indicators around using the RITMD devices to monitor potency of vaccines in those areas. We are sure these minutes were not enough, so please stay engaged. We'll be using the hashtag impact teams to continue this discussion over our Twitter handle, and we welcome for any questions, and you can follow us on our website as well. Thank you.
Great, thank you so much, Harrison and Daniel. It's great to hear about the evolution of these impact teams and how that capacity building support is now being tailored to problem solving Peter and the others as well. So I think with that, we can turn it over to the Q&A portion of this session. Great. Hi, everyone. This is Adriana. So I think just to say good morning, good afternoon, good evening to everyone. We just heard 3 illuminating presentations on different strategies for better data use and on triangulating multiple data sources for data use and decision making. I want to thank everyone for your participation in the chat so far. We have a number of questions lined up. So maybe we can just go ahead and dive in. I noted from Usman and from Andrew a couple of questions that maybe get at some data quality. So, for example, Usman said that you can have a triangulation exercise at 2 different levels that maybe lead to different findings, and what would you recommend in such a situation? And Andrew asked a similar question about the impact of data quality on outcomes. So I'm wondering for our panelists, perhaps maybe Angela or Heather want to comment on this question of how to know which data sources are reliable and how data quality fits into this picture. What could you recommend when you see triangulation exercise that come up with different findings?
Sure, maybe I can start. I'm Heather Scobie. So in terms of the question about getting different results at 2 different levels, I think I'd recommend, it sounds somewhat obvious, but I'd recommend for the 2 levels to talk to each other. And I think, based on our experience, that may not be happening enough. So in part, I think, what we're trying to recommend in the triangulation guidance is, simple things like increased collaboration across units, across levels in terms of working with and interpreting the data. In terms of issues with data quality, I think that that's one strength of triangulation, that you have a more deeper understanding of the data through using multiple data sources. So some of the data quality issues become more clear when you're looking at multiple data sources together. It's not to say that you're always going to come up with the perfect, correct answer. Doing that is difficult, but certainly you gain a deeper understanding. You gain a perspective that you didn't have just by through trying to make sense of the multiple data sources than if you were just looking at one on its own. So maybe I'll stop there and see if any of my colleagues have any other comments.
I think that's great, Heather. Maybe to move on to our next question, we have one from Lisa that in order to triangulate data, health workers need to have access to various sources of data, understand how to interpret it, and be able to apply it. to programming. So what is the biggest barrier to be able to triangulate and use data? And do we think that this is something that can be achieved on a routine basis? So maybe I'll ask Amare or anyone to jump in and see, is this something that we see as achievable on a routine basis, and what are those barriers to making it something routine?
Thank you, Adriana. This is Amare. Good morning, good afternoon, good evening, everyone. So let me try some of practical issues for the challenge at the ground level. The first is one, availability of the standard tools at for health workers at the facility level. That is one issue for data triangulation on a regular basis. Unless we do have a standardized tool, health workers cannot record those important indicators. That's the issue. The other issue is still the chronic problem is skill gap. Unless the health workers do have that skills and capability, just what are the important data sources and how to bring those data sources together, so they cannot do the triangulation or using of data from different sources and then compare between these data sources and come up with some finding and interpret, understand, and use for program improvement. So this is the barrier. So the barrier can be elevated with skill building or capacity building at all levels. So this capacity building is one that is out of this traditional training system. So we should create a mechanism how to provide a practical exercise at the facility level, so that that the supervisors especially do on-job training, coaching, mentoring, availing of those standard tools for supply chain program, for immunization program, so that the skills and capability of the health workers can be improved. Then they can also able to use their own data for service delivery improvement. So these are some of the strategies just to how to improve use of data on a routine basis at the lower level. Thank you. Over to you, Adriana.
Thanks. I think there's another good question here for Harrison and Daniel about fostering a data culture, especially at lower levels, at facility and district levels, that facilities often have data, but they that there's a requirement to encourage data literacy exchange. And then you also have to have this openness to kind of discuss errors or challenges in what you're finding. So Harrison and Daniel, how have the impact teams helped to address this issue of fostering a data culture?
Thank you, Adriana. Thank you, Ben, for asking that interesting question. I think I saw also Laura asking a similar question around building data culture for at facility and district level, the lower levels, given that those are the areas where most of the data generation is done, and that's where most of the data is available. So I think what we are learning is, though this is where all the data is, because most of our programs have been centralized for many years. So we have built up very good reporting systems, but no feedback systems back to the facilities to let them know on the insights and also to request them to take action. So what we're also learning is that because our data collection system is more on reporting, so even the indicators that we are looking at, coverage, for instance, is good, but also for facility level, maybe for them to be able to plan. Maybe you want them to start looking at what will be, how many clients will be coming this month instead of how many came, so that they can plan and address those issues. So that is more interesting to them than looking at historical. So I think what we are learning is, and we are learning this as we are trying to roll it out at the facility level, is we begin by even at when we are forming the teams, we work with the team to identify which indicators they prioritize and how they want them to be visualized. So we include them in that process when we are designing the decision support tools, so that it is useful for them. I think that's one way we are trying to address that, but we recognize there are a lot of challenges at the lower level, given that even the tools that there are not many good electronic systems at the facility level. So we still have to rely on the existing paper-based systems at those levels, which may not always be easy to help with the decision making, but we are training them as is.
Great, thank you so much. So it looks like we do have to wrap up, unfortunately. I want to thank everyone again for your active participation. And I guess just as a parting word, I will say that there's a number of resources that we have available, because this is just an enormous topic to try and cover in 1 hour. So we do have quite a number of links and resources that are available, both what's been shared in the chat, but also it will be on the TechNet website as part of the resources after this session. And if you do have any questions, please feel free to reach out to any or all of us. And thank you very much.